Hello, everyone. I'm so glad you're here today. We are going to talk about precision under pressure, where rapid response meets stroke volume guidance. My name is Angela Craig, and I am a clinical nurse specialist by training, and I am a senior medical manager with Baxter Medical Affairs. I also still work at Cookeville Regional Medical Center as a clinical nurse specialist 1 day a month, and I am a Sepsis Alliance Advisory Board member. And I'm bringing this information to you as a duplicate from NTI, one of the booth talks. So, we're going to talk today about how stroke volume guided resuscitation principles can be integrated into rapid response. And we're also going to do a case study approach and apply these real time stroke volume assessments to guide fluid and vasoactive therapies. So we know that rapid response makes a difference, right? This has been well studied, and you're going to see multiple studies that are just popping up here on the screen that just show us that this has been well studied, that we know that if we do have rapid response teams, it can make a difference in our patients. So how can we make fluid management more precise in these rapid response settings? Well, we know that individualized assessments can help us determine if patients are fluid responsive first versus just giving fluid. And then we want to understand and make sure everyone is clear that IV fluid is a drug. And then treat the way the patient's heart will respond, not just the condition. So, if we think about this, what if we did the following when our patients started dropping their blood pressure? What if we performed a dynamic assessment? Why would we do that? So glad you asked. To see if our patient's heart can take and receive the fluid to allow forward flow and improve perfusion. Now, you may hear me say that throughout this talk, but that's really what we're doing. We're testing that patient's heart to see if at that moment in time it can receive the fluid to allow forward flow and improve perfusion. If not, then we may need to think about other things to do for the patient instead of fluid. So, what is a dynamic assessment? Well, dynamic assessments are a way we can test the heart to determine if their stroke volume will increase with a fluid bolus. Now, we can do this two ways. We can do a passive leg raise, as you can see here on the left side of the screen. How we do that is we bring that patient in a semi-recumbent position as high as they can tolerate their head of the bed so that all that volume moves away from their heart down to their lower extremities. After that baseline period, the monitor will let you know that it's time to lay the patient flat. And we lay the patient flat, we lift their legs, and very quickly that will challenge the heart to see if that stroke volume will increase by 10% or greater. The one thing I failed to mention at the beginning of this, yes, you have to attach technology, whatever technology it is you use, so that you are actually getting a stroke volume measurement. Okay, stroke volume, we also get cardiac output, cardiac index, it can be very, very helpful. The other thing we can do is do a bolus assessment. So that's where we have a 3-minute baseline, and then we challenge the heart. And how we challenge the heart is by giving 250 mils in less than 5 minutes or 500 mils in less than 10 minutes. Now, this is faster than 999 on the pump. This is putting it on a pressure bag and slamming it into the heart, right? Okay, so that's the two ways we can do a dynamic assessment. And usually we do that on a patient who has, let's say, a low blood pressure, a low MAP, they have a perfusion problem like low urinary output, maybe a high lactate. We're thinking, do I need to give fluid? And the other patient population I want to mention is those patients with heart failure and renal failure that we're a little nervous to give fluid to, right? They have a Frank-Starling curve too, just like regular other patients do. And so we really need to make sure we're giving fluid if it is warranted. I love to quote this study, Benser ETAL, about dynamic measures. Will this hemodynamically unstable patient respond to a bolus of intravenous fluid? I don't know if you're aware of this, but only 50% of patients are fluid responsive, which means only 50% of the patients may benefit from additional fluid resuscitation, which then means 50% of the patients won't benefit from additional fluid resuscitation. Well, I don't know about the ICU you work in, but the ICU I work in and with rapid response, a lot of times, if people aren't using stroke volume guided therapy, we automatically start fluid, right? That's usually our choice. And I'm not saying if a patient is very unstable, you're not going to do that. You're going to do what you feel is best for the patient. However, as soon as you can get technology on that patient to see if fluid is going to work for the patient, that is a really great choice. Now, what are we going to do with our results? Well, if they are greater than or equal to 10% increase in stroke volume index, that means they are fluid responsive, which means additional fluid will most likely help to improve perfusion. And so we would use that data along with patient assessment data, and we would give fluid then to improve perfusion. If this patient is not fluid responsive, less than 10% change in stroke volume or stroke volume index, then additional fluid is unlikely to improve perfusion. And we need to look at things like cardiac index, TPR, TPRI to see if vasopressors or inotropic support may be needed. Now let's look at the evidence. So you can see by this study the use of bioreactants in rapid response assessments. This was by Rossiter and many other authors. And I love this study. It talks about using a rapid response team outside of the ICU and in those hypotensive patients. And what they found is that a lot of these patients ended up being septic. Now, the plan wasn't to do a sepsis study, but as you can see here, about 92% of the group they used before they used bioreactants. And by the way, just for clarity, bioreactants is what the Starling, NICOM, or what used to be called the Cheetah utilizes. That's the technology. So this is the technology they used in this study. And they had a group that they reviewed and studied before they had technology. And then they had a group that they used technology. So I'm just going to say bioreactants. So you can see here in this group that did not use bioreactants, about 92% of them ended up being septic. In this post bioreactants group, about 85%. You can also see here that the lowest systolic blood pressure was lower in the bioreactants group. All right. And then you can see also the MAP, which makes sense, is lower in the bioreactants group. And what they did was they looked at these patients and said, hey, are they suitable for goal-directed fluid therapy with IV fluids? They would start a fluid bolus. They would give that fluid bolus about 250 mils over 5 to 10 minutes. If they were fluid responsive, then if it was yes, then they could continue to give a fluid bolus. If they weren't, they considered other treatments for hypotension. Now, you can see here in this study that fluids 24 hours prior was a little more in the group prior to bioreactants, but the fluid 6 hours post was definitely much lower in the bioreactants group. And also that ICU admission rate was much lower in the bioreactants group, which makes me think that maybe we can utilize this and maybe we should utilize technology to help us keep patients out of the ICU. If they just need to be tuned up a bit with volume, you can do this outside of the ICU. So the other thing we found is that the post bioreactants group, the group that utilized bioreactants, you can see the number requiring CRT was much less, in fact 0% versus 20%. And then also you can see ventilation, CPAP or BiPAP was much better in the bioreactants group, as well as now the hours of vasopressors were a little higher in the bioreactants group, but remember also that group was the group that did have a lower blood pressure. Now, this study was underpowered for mortality, or in other words, was not powered really to detect mortality differences with only 49 and 39 patients in each group. The sample size was really just too small to detect changes in outcomes as complex and multifactorial as death. Instead, they really wisely focused on intermediate actionable outcomes like fluids given and ventilation. This particular study talked about bioreactants and how it's associated with a decrease in mortality, decrease in 3-day mortality, as well as a decrease in hospital mortality. And also, those high risk patients had a decrease in mortality. And these are the patients that they also utilize non invasive bioreactants, or the hospitals that utilize bioreactants, and they looked at their hospital mortality. This particular study is a systematic review. It was dynamic measures of fluid responsiveness to guide resuscitation in patients with sepsis and septic shock. And this was a systematic review and a meta analysis. And the question was, does using dynamic measures of fluid responsiveness impact outcomes in adult patients with sepsis or septic shock? There were 9 eligible RCTs and 698 patients. And what the conclusion was that in adult patients with sepsis and septic shock, using dynamic measures of fluid responsiveness may improve survival and reduce the risk of AKI. Also, I want to give a little shout out to University of Michigan. These are their rapid response algorithms that they utilize with bioreactants. Now, they have an algorithm that they use to test with a fluid bolus, and they also have an algorithm they use to test as a passive leg raise. So, whatever seems most appropriate at the time based on your patient condition is very appropriate. Now, let's talk about the levers of perfusion. Blood pressure is just that, it's pressure. Not that it's not important, but remember, that's not our flow parameters. When we look at cardiac output and stroke volume, those are more of our flow parameters because we know that pressure does not equate to flow. So, as we're thinking about perfusion, I want you to think about preload. Think about stroke volume and stroke volume index. Stroke volume is that amount of ejection with each beat, the amount of ejection of blood with each heartbeat. And that normal is 60 to 100. Think normal heart rate. And what we're going to do is perform a dynamic assessment to see if the patient is fluid responsive. Now, remember, we can do that 2 ways. We can do that with a passive leg raise, or we can do that by giving a quick, small fluid challenge like we discussed earlier. The next is the afterload numbers. TPR and TPRI is a surrogate. It's a non-invasive surrogate for SVR. So TPR is called total peripheral resistance, total peripheral resistance index. Think R for resistance. So the lower the number, we think the more vasodilated the patient, the higher the number, the more vasoconstricted. Normal is the same normal as SVR, 800 to 1200. So as we're looking at that patient and we want to know where are they at, as we're up titrating vasopressors, we should be seeing an increase in TPR and TPRI. The next variable or lever is contractility. So you think about cardiac output, cardiac index, think C for contractility. If it's low, you want to ask why. Do we need fluid? And also stroke volume is another one of those contractility indicators. But when we look at that, we kind of rule out whether or not they need fluid first. And then if they still have a low cardiac output, cardiac index, low stroke volume index, then we think maybe this is a contractility problem. And do we need an inotrope? So let's do a few scenarios together. This first one is a patient surgery was canceled due to the patient having low sodium, and the patient was transferred to the step-down unit for monitoring. A rapid response was called when the patient developed hypotension, but yet still had a stable heart rate at 89 and a stable respiratory rate. Stroke volume was 60.4. So remember, normal stroke volume is 60 to 100, so low normal. You can see this index number there. TPR 658. We know normal is 800 to 1200, so that's on the lower side, so a little more vasodilated, right? And then cardiac output is 5.4, cardiac index is 3.7. They did a fluid responsive test and it came back 18.2% responsive with that dynamic assessment. So that means our patient is, hopefully you're saying, fluid responsive. So rapid response was called, and they came to the bedside and they started a fluid bolus for per the provider order. They gave a liter of fluid and did give some albumin. They started the patient on a vasopressor and transferred that patient to the PCU. They did a repeat assessment and it showed 15% fluid responsiveness, so they gave more fluids. Patient was off the pressors by morning and did not have to transfer to the ICU. So this is a PCU unit that allows vasopressors to be given. So I think a key takeaway here is to always assess and reassess with non-invasive hemodynamic monitoring for fluid responsiveness prior to that transfer to ICU to see if you can give fluid and avoid an ICU stay. Now, another scenario is that a patient was admitted for pyelonephritis 2 days prior and received weight-based fluid resuscitation in the emergency department, and a rapid response was called for hypotension. The patient's heart rate was 80 to 90. Respiratory rate was 20, the patient was febrile, and their blood pressure was down to systolic of 80. Stroke volume was 80, so that's normal, right? TPR was 822, which was fairly normal, and cardiac index was 3.6, and cardiac output was 6.2. Since this patient was hypotensive, they did a passive leg raise or a fluid bolus, and the patient was 41.7% fluid responsive. So the rapid response team did start a fluid bolus per provider order. They gave a total of 1 liter of fluids. The patient responded well and was able to stay in the same location. So a key takeaway, rather than just take the patient straight to the ICU, you can assess for fluid responsiveness. If they are fluid responsive, then you have a chance that the patient could possibly be fluid managed on the floor. Now let's do one last case study. And this patient is a 60-year-old female, 5'4", 95 kgs, who came to the hospital for a lithotripsy procedure due to multiple kidney stones. The patient was admitted to the general med-surg floor and went for a procedure and came back to the floor for observation. After the patient had been on the floor for 2 hours, suddenly became hypotensive and labs were obtained per orders. 1 hour later, the labs came back. Patient had hypotension that persisted, so a rapid response was called. And you can see here that the patient is febrile, their MAP is 53, heart rate's elevated, white count's elevated, lactate's elevated, creatinine's elevated, and procalcitonin is elevated. Sounds like a septic hot mess, right? We see a lot of these patients. So the rapid response team arrived and evaluated the patient. The decision was made to use non-invasive stroke volume guided fluid management, and the patient was connected to the monitor. Labs were evaluated, and the priority really now is for perfusion. Remember, this patient had already been hypotensive on the floor, then they grabbed labs. So you can see we're probably behind a little bit because just now the patient's being really evaluated on whether they need further treatment. So is this patient hypotensive or hypoperfused? Well, let's look. We connected the patient to the non-invasive hemodynamic monitor. Stroke volume is 45, which is low. TPR is low at 757, and the cardiac index is 2.7. So we did a passive leg raise or a fluid bolus. Either one can be done. And what they found was the patient was only 4.4% responsive. Is this patient fluid responsive? You should give me a resounding no, right? It needs to be 10% or greater. So based on these clinical findings, what should we consider next? Do we want to give a vasopressor? Do we want to give a positive inotrope? Do we want to give more IV fluids, balanced solutions, even though they're not fluid responsive? Or do we want to give a vasodilator? Hopefully you're all suggesting a vasopressor, because remember that patient has a low blood pressure, stroke volume's low, TPR's low, so they're dilated. So yes, they need a little more, little squeeze, a little pressor to help them out. This patient was moved to ICU so that they could have a vasopressor given to them. The vasopressor infusion started. We increased that over the next hour or two to the institution max dose, and the patient was in ICU now for continued care. Now, you can see that patient's mean arterial pressure has come up to 60. Stroke volume is still low though. TPR did increase, right? And we would expect that because we have started a pressor. And that cardiac index came down just a bit. And remember, as we squeeze that patient, it takes a toll cardiac-wise. It's harder for that patient's heart to pump against that resistance, right? So this patient is still hypotensive with a MAP of 60. So we do another assessment. Remember, whenever you're trying to determine, do we add another agent or are we going to give fluid, then this is a time for us to do another fluid responsive test. So we did that, and you can see it was only a 6.1% increase. So based on this clinical information, what should we consider next? Remembering that this patient is septic, we are going to go ahead and add another vasopressor. So we started vasopressin along with our Levophed that was already started. Pressors continued, blood pressure improved for the next hour, MAP was greater than 65, and TPR did increase. The lactate decreased to 2.2, so we were happy about that. But after about an hour, that cardiac index dropped and stroke volume decreased. The question is this patient still hypotensive or hypoperfused? Well, even though this patient has a normal mean arterial pressure, notice this stroke volume is very low, and notice this cardiac index is incredibly low. That's not good, right? So we're going to go ahead and do a passive leg raise or a short, quick fluid bolus to see if they're fluid responsive. They're only 8.6% fluid responsive. So what might we need to add at this point? We may need to add an inotrope. Remember that as we up titrate pressors, and now this patient is on 2 pressors, that cardiac index is so low, that heart is having a hard time beating against that resistance. So we are going to add something to help it increase the pumping action. So now we have 3 different agents infusing, and 3 hours later, the blood pressure dropped. Stroke volume dropped first from 50 to 42, followed by a drop in blood pressure. And you can see there the 3 drips that are going. Is this patient hypotensive or hypoperfused? Yes, we only have a mean arterial pressure of 61 and our stroke volume is only 42. We do another test, passive leg raise or a quick fluid challenge, and we are now 14.3% fluid responsive. So now we are going to, hopefully you've chosen, give IV fluids balanced solutions. That's right. Hopefully everybody chose that. And so this patient was given a bolus of fluid based on that stroke volume response. After 500 milliliters of LR was administered, the new vital signs are listed. You can see here our mean arterial pressure is up, but our stroke volume is still a little bit low. So since that was still a little bit low, we did another fluid responsive test and the patient was still responsive. So we gave another 500 mils, and you can see here where that mean arterial pressure looks nice. Our stroke volume is now normalized. TPR looks good, and cardiac index has come up as well. So in summary, using stroke volume guided fluid management during a rapid response could improve patient outcomes based on the literature. And also use of stroke volume guided fluid management can help us with the best choice for treatment, preload fluids, afterload pressors, and contractility inotropes. I just want to remind everyone that we have a fluid management medical education website. There's a QR code there. This is where we have multiple webinars and podcasts and things that are totally free for you. And that is fluidmanagementeducation.com in case you don't want to use the QR code. There are multiple references for this presentation. And we want to thank you for your time. If anybody has any questions, feel free to email me at Angela_Craig@Baxter.com. Thanks, and I hope you all have a great day.